And welcome to the Home of Medicine podcast with me, Dr. Amie Burbridge.
And me, Dr. Ben Lovell. Hi, Amy.
Hello. So, Ben, I have a very interesting case for you. And I also think it's a little bit different as well.
Okay.
So,
intriguing.
But also I think it's a case that really challenges me. But I think it's right up your street. So.
Oh, okay. Sounds like it might really challenge me. But you know what? I like to challenge. That's okay.
Exactly. Okay. So this is a case I saw actually quite a little while ago now, but it really sticks in my head. And it was actually a patient I saw when I was a registrar. So it was a very long time ago. But I'm going to start, and it's a 47-year-old man.
Yep.
And you're called to the resus department in the A&E because you have a patient with a decreased GCS.
Yep.
And A&E are a bit stuck. So they call the med-reg for some support.
Okay.
You rock up. The story from the emergency department is that this gentleman was found unconscious in the street, sort of slumped over to one side. He was alone and doesn't appear to have any identifiable information on him. So no phone, no wallet, no driving license, nothing like this. So you've basically got Mr. X in A&E resus. ED want a little bit of support for this patient with a decreased GCS. What do you do?
Okay, I go, first of all. You're right, this is right up my street. I love a puzzle. I love a sick patient. I love resus. I love hanging out in resus. All the really fun stuff happens there. So I'm walking to resus. On the way, I'm thinking, what are my heuristics? What are my shortcuts? What caused low GCS? Something's happened inside his head. So have we scanned his brain for something like a hemorrhage? Or something's happened metabolically. So is he having a massive hypo? Have we done a blood sugar? Or is this toxicity? Has he taken something that has depressed his conscious level? Has he got pinpoint pupils because there's opiates on board, or are there benzos on board? I'm thinking about science for that as well. And there's probably main three differentials, I would say, in a 47, which is still, by the way, a very young patient.
Very young. Very young.
Very young. A spring chicken of a patient. You wouldn't see things like profound hypoactive delirium due to sepsis in someone usually of that age group. So those are my number one things I'm thinking about on the way there, going, is there trauma, and have we scanned the brain? Have we checked him for metabolic disturbances? Primarily hypoglycemia is a big one I think of. Or has there something been ingested? Do we have any clues? I'm also thinking it's unusual that he's been found without anything on him. I don't go out the house without my phone. I don't know anybody else who does. But, I guess you're allowed to pop out. Not everybody's like me. You're allowed to go out without your phone and become ill. And I don't take my ID with me wherever I go. I don't carry my wallet with my credit cards in because I've got everything on my phone. So, I'm not going to draw too many assumptions from the fact he's got no ID on him at the moment. I'm more interested in the puzzle of the GCS. So I'm excited to meet him.
Okay, so you turn up and there's a few doctors around, a few nurses around, and they're not sure what to do. They've stabilised the gentleman. So they've gone through A, B, C, D, E. But actually, the reason they want a medic there is to try and identify the cause of why this gentleman is unconscious and has a low GCS. Now, you said trauma. Now, they've scanned his head.
Okay.
CT head was normal. So there was no hemorrhage. There was no infarct that was seen on the CT. They are considering doing an MRI, although given his age...
Takes time.
Yeah, exactly. It takes time. So they're thinking maybe this is sort of a non-trauma cause of collapse rather than a trauma cause of collapse. So what do you want to do? You rock up and you're in resus. What's your first thing to do?
First thing is I go to the patient with an inquiring mind. Everybody, please keep calm. I don't like shouting. I don't
No.
have a lot of activity at the bedside, but I'm trying to think. So I'm going to go there very calmly and I'm going to do my A2E assessment. And I really want to get that done as soon as possible. I don't know how low this man's GCS is, but the first thing I'm going to worry about is he maintaining an airway? When your GCS drops below sort of 8, 7-ish, 8-ish, this is not a hard cutoff, by the way, just a vague rule of thumb. You do start to relax the muscles which maintain an airway. Your tongue falls back, your secretions gather, and that's when you start choking, and we write about asphyxiation. So I'm going to go straight to the bedside. I'm going to give him a good shake and a shout just to make sure he's not suddenly going to wake up and go, what? And I'm going to assess his airway first of all. Is it patent? Have we put anything in to keep it open? Or is he maintaining his own airway? That's crucially important. That's going to take about 5 seconds for me to evaluate. If I had any concerns about his airway, such as noisy breathing or very difficult work of breathing, then something we might think about is there something to open his airways, such as a Guedel or a nasopharyngeal tube. Then I'm going to swiftly move on to B, and that's going to involve me very quickly looking at his saturations. If a chest X-ray has been done, I'll have a peek at that as well. And maybe I might even dust off the stethoscope and just make sure he's got equal air entry. That won't take me more than 20 seconds to do. Rapidly moving on to C, what's his heart rate and what's his blood pressure? And do either of those two parameters need addressing urgently or correcting? Hold his hand. I always feel peripheries, feel pulses, and get a sort of sense, if I can, about fluid status as well. That's going to take me 20 seconds. Then I can move on to D. Calculate his GCS. What's the score for eyes? What's the score for voice? What's the score for motor? What's the total score? That's going to prompt me to think, do we need to get an anaesthetist down here pretty quickly because the airway might go? Even though we don't know what the cause is yet of his decreased consciousness, we're still allowed to call the airway doctors in an emergency and say, can you come and support an airway whilst we're all scratching our beards and having a think? And then I want to get part of D. I always stick my glucose in D, so I want to get that glucose level. And then E, we better have a proper good look at this patient because it's a bit of a man of mystery. That's going to pull the sheets down, have a look at his tummy, have a look around him. He's not bleeding anywhere. He hasn't got a massive swollen calf because of a DVT. There's not a great big ulcerating infected wound on the back of a leg or incarcerated hernia somewhere or something like that. I reckon I can do the A3 assessment easily within 90 seconds.
Wow.
Give me a lot of information I need, and I can correct as I go.
Okay. Shall I tell you his A2E assessment?
Yep.
Okay. So when you arrive in Resus, you're doing your rapidly quick A2E, which is amazing. So first of all, his airway is patent actually, and you can't hear any upper airway secretions. There's no airway adjuncts in situ at the moment. And actually his oxygen saturations are 89% on room air.
That's too low. Okay. Yep.
Okay. What are you going to do with that then?
Put oxygen on.
Okay.
I think it's a reasonable thing to do. We worry about retention and
Yes.
the narcosis very reasonably, but you look at any guideline, you have a critically unwell patient, you put the oxygen on, and then you look and see whether or not that was the right thing to do. So in terms of someone who's got a decreased conscious level and is hypoxic, I would say, could you put the 15 litres non-rebreathe mask on now? I'll probably will do an ABG pretty soon to make sure he hasn't got profound type 2 respiratory failure, which, well, then I'll correct with any... We'll talk about how I might correct that. But I think a hypoxic sick person gets some oxygen.
Okay. Heart rate, 128.
Bit quick, okay. Regular?
Regular.
Sinus, yep, okay.
Blood pressure, 165/95.
I'm happy with that, yeah. Okay.
Are you?
Well, it's a bit high, isn't it? But at least he's going to be perfusing his organs.
Yeah, okay.
Yep, I worry more about if it was 65 over something and he wasn't. And that would say, oh, maybe he's not perfusing his brain and that's why he won't wake up. But 165 over 95, all his organs are going to get the blood that they need for now. So whilst it is high, I'm not too worried about that at the moment.
Okay. Rest rate of 10.
That's way too low. Okay.
Temperature, 38.2.
Bit febrile. Okay.
And you wanted his glucose as well, you said?
Yeah, let's move on to D. So glucose?
18.
Okay, high. That's high. That's not physiological. That is high. So I wonder if this is a diabetic man, but it's not hypoglycemic, and this should not be causing neuroglycopenia, which would cause a low conscious level. Okay. And
pupils?
Then D, what is it? Yeah, pupils. Yeah.
Dilated.
Right. So not pinpoint. So there goes my opiate toxicity theory, but that's great. Yep. And his GCS.
So his GCS. Now, I'm going to admit something here, Ben. I really struggle with measuring GCS. And
Because you can't remember the parameters and what they
I never remember them.
maybe nobody does.
Really?
Yeah, we all got
Okay.
yeah. And we
Okay.
don't worry.
Okay.
Yeah.
So he's not spontaneously opening his eyes.
Mhm.
There is groaning.
Mm.
But you can't really understand what he's saying. And movement wise, there's a little bit of sort of thrashing about of the arms and the legs.
Spontaneous.
Spontaneous movement,
So not following commands, not
No.
when I ask him.
No.
All right. So let's call that eyes. Did you say it didn't open at all, or did
They are? They're opening, yeah.
Oh,
yeah.
So eyes is 4. V is groaning, but no recognizable sounds.
No.
So that's a 4 or a 4 probably. And movement was spontaneous, but not following commands.
Exactly.
So yes, it's only actually about 13ish.
Yeah.
Which is not as bad.
Mm-hmm.
Okay, as it could be. Yes.
No, that's true.
Okay. Let's move on to E, please.
Okay, so E, you examine him, and he's incredibly sweaty.
Yeah.
He looks pretty unkempt.
Okay.
He's a little bit smelly, so he looks like he may not have washed for a little while.
Malodorous, we would say.
Although, to be fair, after a day in A&E, I'm probably malodorous.
Maybe you were smelling yourself. Yeah. Okay.
Sometimes I do that, and I'm like, oh, it's me, not. And his clothes look like they haven't been washed for quite a long time.
Okay. Maybe this is a man who with no fixed abode. Maybe
Yes, and that's the sort of thought process that was going on in my mind. Actually, was he found on the street because actually he has no fixed abode and he's homeless potentially? Or has he just had, I don't know, just not had a shower for a long time? And that can sometimes happen as well. So that was where my thought process was going. But on the rest of the examination, there was nothing. You mentioned ulcers. There were no ulcers noted. Cars were soft and non-tender.
Yeah.
There were some random bruises on this gentleman's legs, on his arms and his chest, but nothing significant. Heart sounds were normal. Chest was clear. Mm-hmm. Abdomen was soft and non-tender.
No injection marks anywhere implying intravenous drug use?
Not that were obvious.
Okay. And you said heart sounds were normal. No split hemorrhages on the nails.
No. No. To be fair, at the time, because he was very unkempt and quite dirty, there was a lot of dirt down the nails, and the hands and the feet were very dirty. And I always think you can tell a huge amount about a person, I've said this many times, from looking at their fingernails and looking at their toenails. So couldn't really see any splinter hemorrhages, but it was obvious that this gentleman wasn't really looking after himself very well.
Okay, so let me see if I can tie this together.
Okay.
The hypoxia and the low respiratory rate, that demands a blood gas. I'm worried about him hypoventilating, and that means he will be building up CO2, which could be contributing, maybe in part, if not wholly contributing to his decreased GCS. We definitely need an ABG. That ABG would also give me some useful information, for example, with regards to lactate.
Yeah.
It would also, if it showed a metabolic acidosis, that might tie in with my next requested test, which would be for a point of care ketones. If this man has got a CBG of 18, could there be an element of early DKA? It's not very high, but if he's a diabetic, it's ketonemic, that would show up on the gas as well. So I'd like the ketones as well as the ABG. And as a side note, it is very, very difficult to be an insulin-dependent diabetic if you're unhoused, because you just have you have no fridge to put your insulin in, and you can't store your needles cleanly. So they really, really struggle. Now, look, he's febrile as well. Now, this could be infective.
Okay.
Your central nervous system infection, such as encephalitis. That's one thing I'm thinking about now. Septic in any infection in addition to something else what's going on. The other thing I'm thinking about is his GCS low because he's post-ictal? Did he fit because you do get a SIRS, an inflammatory response, and a temperature spike after you have a grand mal seizure. So the only other thing I'd be thinking about looking at him, are there any subtle signs of ongoing epileptic activity, such as eye flickering or strange semi-purposeful hand movements? Or is his lactate 17? Anything else that I could point towards? Maybe did this man have an unwitnessed seizure in the street and has now been found in a profound post-ictal state, leading to hypoventilation and a temperature spike? That might tie a few things together neatly. The last thing to mention is the dilated pupils. Now, this goes against opiates, but it could be a toxidrome. So I'm thinking high temperature. I'm thinking dilated pupils, very sweaty, hypertensive, tachycardic. Has he got either, what kind of toxidrome? A sympathetic mimetic toxidrome? Has he something that stimulated his sympathetic nervous system and dilated his pupils and made him tachy? They tend to be agitated rather than sleepy, unless it's like the very late stage. Cocaine, amphetamines, things like that. Anticholinergic toxidromes would give you a dilated pupil. What on earth would they have had that would cause that? An antihistamine overdose, a tricyclic overdose would cause that. All right, let's make a shopping list. I'd like, please, an ABG. I'd like his full set of bloods done, please. Let's do some whilst we're bleeding him, because he is febrile.
Okay.
And after I've got the information, I'm going to take a view about how I'm going to resuscitate him.
Okay. Would you give antibiotics at this point?
Not yet.
Okay.
Does it trigger for sepsis? No, I can see my air quotes. Trigger for sepsis. Fever, tachycardia. Potentially, yes. To be honest, I'd be surprised if ED hadn't already given him some cefuroxime now, which I think is very reasonable. But at the moment, we have time.
Do we?
I want the lactate.
Okay.
And I want to have another little think. My threshold for giving antibiotics is super low, so I will give them very easy without any panic or cause. But I want those tests. I want to review those results first.
Okay. Lactate 6.
Yep. That's too high. Okay.
You mentioned ketones.
Yeah.
1.4.
That's high. Okay.
CO2.
Yeah.
6.
That's upper limit normal.
Yeah.
Okay. And his other parameters on the ABG, his PO2?
PO2 is now on 15 litres of oxygen, and it's 15.
Okay, that's low. Someone's on 15 litres of oxygen, you'd expect their PO2 to be something like in the 60s or something like that. So there's a VQ mismatch there, right? Okay.
And pH is 7.37.
Normal values. Bicarb?
Bicarb, I didn't write that down.
Probably because it wasn't abnormal or important then.
Maybe.
One assumes. Right, this is getting really interesting. So let me see.
Yeah.
My pen and paper out now. So on one hand, we have a gentleman who's febrile, tachycardic, and a lactate of 6. Fine, you've convinced me. Let's treat for sepsis. So I'd like 1.5 grams of IV cefuroxime, please, as broad-spectrum antibiotic. That's my local protocol for infection.
You mentioned encephalitis.
Yeah.
Would you give acyclovir?
I'm still thinking.
Okay, sorry.
So IV Kef, that's going in, please. 1.5. All right, what else do I want to give straight away? He's ketonemic and he's hyperglycemic, but not acidotic. I need to clear his ketones, so I'm thinking about a variable rate insulin infusion, what we used to call a sliding scale, or even a fixed rate, actually, to clear the ketones. I think I might do that, actually. Let's start a fixed rate insulin infusion to target his glucose levels to be between 7 and 12. And when they get to that level, we can add in some dextrose to avoid hypoglycemia. But let's clear his ketones. I didn't have his blood results yet. Does he have a sodium in his U's and things like that, please?
Yeah, absolutely. So his sodium is 148.
Just above normal, okay.
Yeah. He's got a potassium of 4.1.
Normal.
He's got a urea of 19.
High.
And a creatinine of 232.
Okay, so that's a kidney impairment. We don't know his any previous results, so we don't know if it's AKI or whether it's his usual renal function. On the side of safety, this is an AKI. All right.
Hemoglobin is 120.
120.
Yeah. White cell count is 14.2.
Yep.
Neutrophils, 10.4.
Okay. CRP?
76.
Okay. All right. So we're going to treat for sepsis. I've said that. IV
Okay.
care. We're going to try and get his insulin and his ketones into normal parameters with an insulin infusion.
Mm-hmm.
Look at his breathing and his ventilation. He's got type 1 respiratory failure, and he's not retaining. I mean, 6 is the upper limit of normal for CO2, but I think we can go up with the insulin, with the oxygen a little bit, and target SATs of 94 to 98. We've got no indication that we shouldn't do that. So O2 goes there. Let's do the full sepsis 6 and give him some IV fluids as well. It probably would be a good idea to catheterize him to measure his urine output, thinking sepsis 6 here, and blood cultures we mentioned already. Now, what am I going to do now about his GCS? I have to make a decision about whether to treat him for a central nervous system infection or not. Febrile, decreased conscious level, no detected or witnessed neurological impairment. Although we said he might have fitted. Ooh, I think I might, I think I might. Acyclovir, yeah. Acyclovir, very safe drug. Sometimes causes an AKI, so you have to keep an eye on his renal function over the next few days. But thinking here and now, we're looking at acyclovir and a lumbar puncture, aren't we? Lumbar puncture realistically is going to come first before the MRI scan, and he's a bit of a ropey transfer to MRI at the moment. You'd have to go with anaesthetic support in case he lost his airway whilst in the scanner. So I might be doing an LP on this chap right there and then research. It's a good opportunity. GCS 13, he might lie still for it.
Okay.
Yeah.
That's not a bad thought, actually. Yeah.
Yeah. The logistics are always interesting when it comes to lumbar punctures and the acutely sick.
So, where are you at the moment with what's caused this? So you've mentioned infection, you've got him on cefuroxime, you've mentioned encephalitis, you started acyclovir, and you want to do a lumbar puncture on him and sepsis. You've also thought, could this be postictal? And you've also mentioned doxydromes. We don't know which one of those this is at the moment.
Correct.
What are you going to do apart from the LP?
Apart from the LP and the resuscitation measures I've mentioned, the LP is realistically going to keep me busy for a couple of hours.
Yeah.
Finding the kits, getting the position, getting the label, sending them off, all that sort of thing. And I think that's fine. And then I'm going to see what happens next. I'm quite comfortable holding a list of differentials in my head for a few hours and then seeing which one, comes to the front of the race as time and results sort of start dripping back. One thing I could do, I suppose, is ring that very clever poisons helpline and just say, look, I've got a man here. He's febrile, dilated pupils, bradypneic, hypoxic, tachycardic, normal muscle tone, I'm assuming, or you would have mentioned he was hypertonic or does this fit with any known toxidrome? They're awfully clever, these people. And they might come back and say, you should screen for this or treat for this. This sounds like they could have had an overdose of this kind of GABA receptor, and maybe you should treat them with baclofen, all that sort of thing. So if I thought toxidrome, that's a useful resource. Don't do it very often.
Yeah. So you're talking about calling the National Poisons Helpline, the National Poisons Agency, or ToxBase as well, which we can also access, can't we? Absolutely. So earlier on, you mentioned that he could have overdosed on a how did you say it again?
Right. Sympathomimetic. Sympathomimetic.
Sympathomimetic. How fast can you say that?
Sympathomimetic.
It's really hard, isn't it? Okay.
It's not as hard as parasympathomimetic, though.
Oh, God. Right. I can't even say it. Okay. So you've treated him for everything and you've mentioned drugs, and absolutely you speak to the National Poisons Agency, which is what I did.
Oh, good.
And they suggested that, yes, this could be a toxidrome. And actually, this could be a potent sympathomimetic.
Many M's in that, but yes.
Yeah. And basically that activates the sympathetic nervous system. You've got lots and lots of adrenaline, lots and lots of noradrenaline. Basically your body heart rate goes up, which you've talked about, your blood pressure goes up. your pupils become very dilated, you become very sweaty and quite agitated, actually. And the things that they suggested that could cause this are cocaine, which you've already mentioned, amphetamines.
Yeah, I said that.
And you did, and
Yeah.
spice.
Oh, okay. Yeah,
Have you heard of spice?
I have.
So I don't mean nutmeg, I mean, or coriander, I mean a synthetic cannabinoid spice.
Yes.
Have you seen a lot of people taking this, overdosing this on this?
To be honest, I haven't. I've seen it more in the news than I have in real life, but it can cause profound alterations to mental status, which includes people can lie there in the street with GCS3 for hours on end before they wake up. I don't know if I've, I can't remember the last time I ever saw one in clinical practice, though.
So when I saw this gentleman, this was when I was working in Birmingham, inner city Birmingham.
Yep.
And we know that inner city Birmingham has a problem with spice. And we know that the bigger cities, Wolverhampton as well, has a particular problem, as well as other towns and cities throughout England. Spice is a problem, particularly amongst the homeless population. Now, the way that spice works is it is a synthetic cannabinoid. So it activates your cannabinoid 1 and cannabinoid 2 receptors completely. So it's a complete agonist of all of the receptors. So you get this extreme sympathetic nervous system stimulation where everything goes wild, and then all of a sudden you get the crash. And that crash can lead to disassociation, decreased GCS, respiratory depression, seizure activity. And there is a thought process that individuals who are homeless, it's particularly prevalent in the prison population as well, because it allows them to dissociate away from actually what is happening to them and get away from the homelessness.
Like ketamine has a sort of similar.
Yeah. Absolutely. So when I was working in this particular place as well, it was opposite a very well-known prison. And what I didn't know is that a lot of spice, the latest statistics from 2025 on the government websites, are that 50% of prisoners use spice. And that's because spice can be sprayed onto paper and it can be on a letter that's sent in to the prison and it can be ingested.
Blimey.
And I remember one of the prison wardens telling me this and I was like, what? This is crazy. But yeah, it's quite easy to actually get into prisons in that respect. And the fascinating thing about synthetic cannabinoids is it's very difficult to detect on drug tests because the people who make them continuously change the synthesis of the cannabinoid, always evading detection. There is no treatment for synthetic cannabinoid overdose. It's supportive.
Yeah.
It is.
I suppose the low respiratory rate threw me there a little bit because I would expect him to be agitated. But I guess if he's been on it for several hours and his nervous system's starting to crash, that's very
exactly.
But treatment is supportive with things like benzos. And oxygen, although I wouldn't be giving benzos to someone really with a GCS 13 outside of an HTU ITU setting.
No, absolutely. And you're absolutely right. So the temperature, you can cool potentially if that's something that, again, I'd probably want to do that in a supportive environment. Benzodiazepines you mentioned as well. Again, with the GCS, you'd probably do that when he's more agitated in that sympathetic overdrive rather than the sympathetic crash. ECG can sometimes get prolongation of the QT interval, so you might want to monitor that. Consider maybe magnesium to support the cardiac myocytes. Check your CK, because the CK can still go up. Now, there is also now huge amount of synthetic opioids. Have you seen anybody overdosing on synthetic opioids?
Again, no. I live by a sheltered life, obviously, unless I've seen them and I've missed it. But I don't think so.
So the synthetic opioids, again, made similarly to the synthetic cannabinoids, they're continuously evading detection. They're They're like a retrovirus. You know, retrovirus are continuously evading detection. That's what these synthetic opioids and synthetic cannabinoids are. And they're called nitazines, I think. Nitazines.
Yes.
Yeah, I'm right. And a lot of people now have polydrug overdose.
Right.
So the cannabinoid is mixed in with the opioid. So there is a school of thought that actually, if you have somebody come in who's overdosed and you're not sure what it is, you actually give naloxone because it might turn off the opioid toxicity.
Yeah.
Again, school of thought, something to think about.
Yeah, I guess if people are coming in with mixed toxidromes, they're going to be harder for us to detect.
Really hard.
Because they're not going to bundle up neatly into a toxidrome we memorized at medical school or we've seen before.
Muds.
It would be
And,
a bit of this and a bit of that and a bit of the other. Yeah.
If you look at the official statistics, the use of spice has gone down, but hidden spice is going up. And what I mean by hidden spice is the spice that may be in prison population, which has been smuggled in. But really scarily, 1 in 6 vapes last year that were confiscated on school premises had synthetic cannabinoids in them.
Oh my gosh. Okay.
Isn't that frightening?
Yes, for someone who has a 2-year-old daughter who's going to school in a few years. Yeah, that is quite frightening.
Isn't it just? Yeah. And this takes me back to a couple of patients I've seen within the last couple of years who have had vapes which have been contaminated. And at the time we didn't know what, but actually it probably was synthetic cannabinoids. Scary.
Well, I tell you what I have seen a few times is GHB overdoses. I think that's has a dissociative effect as well.
It does, yeah.
And is used sort of chemsex as well, and it causes profound depression of consciousness. So much so they can be GCS3, they can be intubated in resus, and the offset is insane to watch. It just switches off. They just metabolize it, open their eyes, wake up, yank out their tubes, yank out their cannulas, walk out the door. And you think, God, that patient was fully dependent for respiration 4 seconds ago.
It's wild.
All of a sudden, they're back to normal again. But they're unwakeable, and it's quite shocking how potent it is.
Mm-hmm. Yeah, absolutely. Any thoughts?
I'm thinking just about. I mean, I work in central London. It's not out of the limits of possibility that these toxidromes will be coming in, and I think it's something to have a high suspicion for when you see things that don't quite make sense. What made me go toxidrome when you were telling me this? I think it was the pupils and the temperature, the dilated pupils and the fever. And to me, that speaks of adrenaline. That speaks of your sympathetic nervous system. So what would be sort of ramping that up to the max? So I guess that was a little giveaway there for me.
So this case really made me think about poisoning in general, because I did see a huge amount of, and actually where I was working was it was where the House of the National Poisons Unit was as well. So I guess I was in a space where I saw lots of these type of cases. So I guess that was a bias in itself. And as you say, sometimes I don't think of toxidromes often enough. I don't think of poisoning enough. And I'm not just talking about poisons from illicit drugs, but I'm also talking of poisons in older adults who have a huge anticholinergic burden from the medications that they take, and particularly in the frail elderly population. Some of the medications that they are on can give them quite significant anticholinergic side effects that can be incredibly detrimental to them. And it made me think about, we should be checking and calculating the anticholinergic burden, which there's a calculator online.
There is, yeah.
If we can check, it does give you a score for our patients who maybe have a slightly decreased GCS, or maybe agitated or complaining of symptoms that we really can't put our finger on. Think drugs, think medication.
Yeah.
So
and the anticholinergic toxicity sort of looks a bit like this.
Yes.
You get a bit hyperthermic. You go into urinary retention. You can get those dilated pupils and get a delirium as well. What's the main culprit drugs that you see in clinical practice?
Anticholinergics. So some of the antidepressants can do it.
Amitriptyline.
Which seems to be quite commonly prescribed 10 milligrams Nocte.
Yeah. helping
Um,
with sleep. Hopefully not so much anymore, but yes, someone, if someone says, oh, I've started them on a bit of amitriptyline for their pain, and that's a bit brave. In
yeah,
an older adult, that's a
absolutely.
little bit brave for me.
Yeah. Exactly. What about you? What sort of anticholinergic drugs are you seeing?
What's the one they give for bladder overactivity?
Oxybutynin or
Yeah, solifenacin, those
yeah,
ones.
all of those. Yeah.
They're not uncommon in elder
Mm.
adults as well, and they can do it as well.
Mm.
I think also tramadol can have quite a cholinergic burden as well.
Yes.
And I do see that sometimes. And tramadol is such an ineffective painkiller. We really shouldn't be giving it to anybody.
No, exactly. I'm just I agree. And I think years and years ago, tramadol was like the big drug, wasn't it? But it's not something again that we tend to see a lot of
No.
anymore.
I remember when I was a foundation doctor, as part of our normal post-operative packet of drugs, we'd send patients home after they'd had surgery, paracetamol and a bit of tramadol.
Yeah.
Whereas now you give tramadol and everyone sort of reacts as if you're holding garlic up to a vampire. Throw it away.
Yeah.
Yeah.
But also sertraline as well can have quite an anticholinergic burden, which
Yeah.
is often used in the elderly as an antidepressant because it has less cardiovascular side effects. So again, it's that balancing act, isn't it, of risks versus benefits of the medication.
And there's a synergism. They work together. So group 1 to 3
They
of
do.
them. Yeah.
Yeah, absolutely. So I hope that was an interesting case for you, Ben, and it got you thinking.
I love cases like that, and I love working in cases like that. I was going to say it when we were in resus when I was looking at the patient. I'm having such a nice time. It's just such a good day at work. I really enjoy that side of medicine, that side of acute medicine, and sort of puzzling stuff out and resuscitating, and treating patients who need you, but also got your thinking cap on at the same time. That feeds my soul a little bit. Why I go into work.
It's like that is what we do as acute physicians, isn't it?
Yeah.
That's what I love doing. Yeah. So I'm going to end on a quote from Paracelsus. Have you heard of Paracelsus?
No.
I can't believe it. So Paracelsus was a physician long time ago, like the 1700s. And he said, everything is poisonous. It's the dose that determines it. And also, what I really liked about this gentleman was that he was very new in his way of thinking, and he was very sort of anti the Greek way of medicine. And he was very much one of his sayings. I mean, you don't know whether this was actually said or not because it was 400 or 500 years ago, but he was the first physician who said looking at the patient is where you get the clues. So I really like that. Absolutely. So well done, Paracelsus. And Ben, thank you so much. We've covered so many things there. We've covered toxidromes, polydrug poisoning. And I think the key thing there is to our listeners is to think anticholinergic burden, think spice, think synthetic drugs because they sometimes evade detection.
And if in doubt, ring an expert. Ring the national police. Sounds like they were very helpful in your case.
Yes. Yeah. Thank you to everybody for listening. Please rate, review, and subscribe to the podcast. Thanks for listening. Goodbye.
Bye.